Hello, future nurses. It is Julie here. We are going to quickly go over Unit 2. My goal with all of these is to do it in less than an hour. So we'll see how well I do today. Unit 2 does start off with functions and activities of the brain. So remember, this is a lot more of those knowledge-based skills. So we generally, even in lecture, went through this pretty fast. So what does our brain do? It maintains homeostasis. It controls our biological drives, that circadian rhythm, that 24 hours of sleep and wakefulness, all of our conscious mental activity. I'm going to schedule a task. I'm going to make a list for what I want to do today. That hippocampus and memory, our social skills, how we interact with other people, that all comes from the brain. And any alteration of the brain affects those things. Our brain is made of neurons, and we have hundreds of billions of neurons, and they conduct electrical impulses. Most of the functions of the brain result from the actions of individual neurons and those connections between them. Now, one of the main things that these neurons do is release neurotransmitters. We watched this very brief video in class. We're going to skip over it today. This is kind of what it looks like. So we have those dendrites, those spiky things all the way on the right. Action potential moves down to those axon terminals, and then we have that synapse, that gap between. Our neurons send neurotransmitters from the axon terminals to the dendrites of the receiving cell. Depending on what we're doing with our medications we'll see this quarter, we're going to affect what's in the synapse. So at simplest, the one we talked about are selective serotonin reuptake inhibitors, SSRIs, Zoloft. Our whole goal is to increase the amount of serotonin that's available in that synapse. Now, these are our neurotransmitters. This is that direct table from your textbook. We're going to talk about a few of them that we see frequently throughout the quarter. Dopamine, right? Fine motor movement. If we see decreases, it causes Parkinson's. An increase in dopamine causes schizophrenia. We also see dopamine involved in pleasure. We'll talk about this a lot when we get to substance abuse. Norepinephrine is a common one. This is our fight or flight. It is at attention and arousal. If you are all of a sudden getting chased by a lion, norepinephrine is very much in play. It gives you that energy to run away, to pay attention to what's going on in your surroundings. Serotonin is another one that we see frequently throughout the quarter. Our SSRIs are first lines for so many different choices. For so many different medical conditions and psychiatric conditions. It does a lot those basic drives: sleep, hunger, mood, pain, aggression, sex. All of that is serotonin. GABA. GABA is our primary inhibitory neurotransmitter. So it calms us. It reduces aggression, excitation, and anxiety. So if we see an increase in GABA, we see a reduction in anxiety. Glutamate is an excitatory. It works a lot with learning and memory. We see it in psychosis along with Alzheimer's. Acetylcholine is another one we see in learning and memory. Too little, we have Alzheimer's. It is very much like it says that resting and digesting, where it is again calming. Now, when we look at the activities of the brain, we do have all of these tiny little places, different lobes, and we even have more lobes and more parts, not lobes, but we only have a few lobes, but more parts than what is listed here. We are keeping this a very 50,000 feet view. We are not going too close in. Our brainstem connects directly to the spinal cord. It's central to survival. Heart rate, breathing, digestion, sleeping. Without your brainstem, you will die. The hypothalamus is above the brainstem. And it controls basic drives: hunger, thirst, sex. It helps regulate sleep. If we have patients who have difficulty with extreme thirst or overeating, it may be a problem with that hypothalamus. The cerebellum is located behind the brainstem where the spinal cord meets the brain, and it receives information from the sensory system, and it's involved in balance and maintenance of that equilibrium. The cerebrum is on top and surrounds the brain stem, responsible for mental activities and a lot of that conscious state of being. So we've already kind of talked about a lot of what these do. That brainstem is doing all of the things that keep you alive, right? Regulates internal organs, all of your vital functions. That hypothalamus, again, are a lot of those basic drives: eating, drinking. Brainstem processes is a processing center for sensory information. What do we have on the next slide? Functions of the cerebellum and cerebrum. Already did that very brief overview on these. Cerebellum regulates skeletal muscle. It maintains equilibrium. This is the part of your brain that is receiving informations from other parts of the brain and helping regulate all of those voluntary movements. The cerebrum is that biggest part of the brain. It is made up of all of the things, mental activities, memory, skeletal muscle, again, language, communication, all of that stuff is there. We have a few different ways to image the brain. CT and MRIs are ones y'all are generally familiar with because we do see those a lot more medically done. If someone has a possible appendicitis, we send them for a CT. If we think they have a soft tissue injury, we send them for an MRI. We can do those for the brain, but a few different things that we can also do, one being the PET scan, positron emission tomography. And a PET scan, these are pictures directly from your textbook. We inject a radioactive substance and it produces bright spots on the brain. So we can see, right, if we have our control brain over here, if we look at the front, there's some small black holes. We have a lot of these yellowish, greenish type dots on both of these. But when we get to someone who has depression, that yellow greenish dots disappear, the holes are getting bigger, and there's a lot more red. So that radioactive substances that is causing these bright spots allows us to track this information. So we can see a difference, especially in this patient, in that prefrontal cortex, that front of the brain, where these things are different, where we're seeing decreases and changes in brain activity. So what happens? All of these things can cause a disturbance of mental function, right? If you use methamphetamine, that is going to increase your dopamine. If you drink alcohol, it's going to decrease your GABA. If you get sick, your body has to work differently, right? Teenagers, their hormones, everything is changing. If we have psychological trauma or if we have physical trauma, Phineas Gage took a metal rebar pole through the head and it changed his personality. Genetics plays a big role because how your body processes this information, how your neurotransmitters come into play are all affected by genetics. And then, of course, anything that disrupts our neurotransmitters, anything that alters that chemicals in the brain is the basis of a psychiatric illness, and it's the target for why we are giving these medications. When we can understand the alterations in neurotransmitters, it will lead us to a better understanding of treatments and possibly preventing mental disorders. We're just not quite there yet. Not us in this class, just in general, because we don't always know why things happen. This is the structure of neurotransmitters, kind of a good picture of just another overview, what they look like. So we have psychotropic medications, and we are not studying those medications at this point in time, but we're going to look at how a lot of them work. So pharmacodynamics is what the drug is doing to the body and how they respond. The drug has an action, and then there is a response. Depending on our individuals, when we talk about pharmacogenetics at the bottom, honestly, pharmacogenetics affects dynamics and pharmacokinetics. How we all respond to drugs are affected by more so than just what the medication is. We talked in class, individuals with red hair need higher levels of anesthesia. That's a known fact. Individuals of Asian descent need some specific genetic testing before we give them some mood stabilizers because their body reacts to them differently. Pharmacokinetics is specifically how the drug is moving through the body. So simplest, absorption, how we're absorbing the med, distribution, how the med is spreading throughout the body, metabolism, how we're breaking it down, and excretion, how it's leaving. So if you go take your B complex and all of a sudden your urine is this like bright yellow orangey color, that is because we're not using all the medication. Our body broke down the B12, it spread it out to where we need it, and then as it was starting to metabolize it, we got rid of the excess of it. Pharmacogenetics, we've already talked about the genetic variation leads to differences in how we respond to medications. It very well could be individually. It very well could be ethnically. We have two other words not on here that we'll see. And I talk about them because some of y'all struggle with these throughout the quarter. An agonist is going to mimic the effect of the neurotransmitter. So this is a stealth. They're dressing up in a costume. They're saying, but I am really serotonin, and it is going to bind to that serotonin receptors and it's going to stimulate it, but it is not actually serotonin. Y'all gave a really good example of class of tramadol. Tramadol is not an opiate, but it has those opiate principles. It goes to the brain and says, but please, I promise you, I am an opiate. Let me sit here. And it sits in the site and it causes activation. An antagonist blocks the neurotransmitter by obstructing the neurotransmitter's action. So this goes in that antagonist and it acts as a goalie. It closes it off. And it is basically going to that receptor site and it is forming this big defense. It is covering it and saying, you can't come here. So then we stop that neurotransmitter by working. And that is it. 10 minutes, we have covered all we really need to know about the brain and the basis of psychotropic drugs. We are switching gears into complementary and alternative medicine. So remember, some of this stuff is here just so you have an understanding of what it is, especially on this side. So complementary medicine is non-mainstream medicine in conjunction with standard medical care. Alternative medicine, we are only using non-mainstream in place of standard medical care. Integrative, we are using non-mainstream medicine in conjunction with standard medical care, but in a coordinated way. So we talked about my little one in class. He has autism. We are working with his psychiatrist, and she very much does a lot of the integrative psychiatry where we are coordinating diet. We're looking at supplements, whether it's fish oil, magnesia, melatonin, and also throwing in guanfacine, a medication to help with his ADHD. So we're kind of working to coordinate all of these different complementary alternative, everything, to make kind of a holistic choice for him. So 40% of patients are going to use some. Conventional healthcare, and we'll see a few different words for it, it's what it's done to the patient. Health means you're not sick. However, when we look at more integrative practices, it's with the patient. It is very much more holistic, more patient-centered. And health isn't just, I'm not sick. It's that everything, spiritual, social, emotional, mental, all of those things being nice is nice and connected. Conventional healthcare has a few different names. Allopathic, orthodox, Western, biomedicine, all the same name, just to say the same thing. So we can talk about Western medicine, we can talk about conventional health care. We're just switching those around. For the most part, right, these are new. It's only been around 200 years. Well, we have seen CAM practice worldwide for thousands and thousands of years. And conventional healthcare is very much regulated. We have the science, we have organizations, we have the FDA, we have the NIH, we have all of these different things that are regulating it. We do have some different groups, some different professional organizations that help us regulate, that's looking at doing that evidence-based practice and getting the information out there. The National Center for Complementary and Alternative Medicine is one. There is another one specifically for nurses. So when we talk about consumers, why do people want to use all of this CAM, this integrative care? Well, they want to participate in their healthcare. They want a holistic approach. Maybe they've had a positive experience before. I had this provider. They were very supportive. It made me like this better. They also could just be dissatisfied with conventional medicine. You're in, you're out. Go see your provider, right? They look at you for 2 or 3 minutes. They tell you what to do. They send you on your way, and you don't get that discussion, especially when we look at mental health, because most of our psychiatric providers are only seeing their patients for maybe 15 minutes. That is a big one in mental health that drives people to other types of providers. So when we talk about integrative nursing care, we need to know the basics of everything. We're never going to be experts in all of this. However, we want to make sure we can provide safe and effective care for patients who are using these different modalities. And we need to understand, so when patients ask questions, hey, my doctor said this, but I would really like to try essential oils. We can provide them with some, even if it's basic, education. I was talking to Professor Archibek, y'all probably know him as PJ, after class on Friday, and somehow this holistic integrative nursing care came up, and he even brought up, when he started nursing, especially in mother, baby, labor, and delivery, essential oils were everywhere. But we're looking at the safety of it. They're still using it quite frequently, but we need that doctor's order. So the nurses have to kind of have that understanding of what oils they are using and why. So holism in nursing is something you have probably heard before. We are greater than just our parts. We are, as a patient, as a person, a combination, psychosocial, spiritual dimensions. And we have to understand that whole process, all of those parts, and how we interact with our environment to provide our patients that best nursing care. So we're going to talk quite about a few of these. Today, this is kind of our table of contents for the different types of integrative care. Now, we're going to stop after energy therapies. We will see the rest of them throughout the quarter, and we'll go into more detail later. So today, we're really going to focus on natural, mind-body, manipulative, expressive, and energy therapies. Bioelectromagnetic light we'll talk about when we get to depression in a lot more detail. And then prayer and spirituality, we've kind of covered a little bit as we've gone through culture. So we have a bunch of natural products. And we have this huge link between diet and nutrition and mental health that is often overlooked. There are so many different components of our diet that do affect mental health. Few that we have pulled out and listed, right? We talk about vitamin D. Vitamin D, there is a positive link. Vitamin D decreases depression a lot by lowering that oxidative stress and inflammation. Omega-3 fatty acids reduce your risk of depression. We see lower incidence of depression in those who are eating more fish, raw fruit, vegetables. Microbiomes. We have studies on probiotics, prebiotics, on fecal transplants in our patients. So these very much are things. Those with mental health disorders often have poor diets, and in addition, metabolic disturbances often occur as a result of treatment for mental illnesses. A lot of our medications, obesity and diabetes often occur in higher rates in those with psychiatric disorders. Anemia is often accompanied by depression. The traditional Western diet is often called the standard American diet, and we have a lot of processed foods with little nutritional value. And we see that link between inflammation and depression. We have studies that show there is more depression with the Western diet. And even when we look at it, stress. When we're stressed, we tend not to eat the best things. So stress plays a huge role in our poor dietary habits and depression. We pulled this out and we looked at it briefly. This is one I found interesting, more so because I have that little one at home. Broccoli reduces symptoms of autism, and we've done, randomized double-blind study. This is not like a case study. Granted, they didn't have a huge amount of people who participated, but we are still looking at this research. And when we do one tiny study, we then can replicate it. Now, one of the things when we get into dietary supplements that we're going to talk about, and this is exactly, I copied this Thursday from the FDA website, so early April. Most of our patients don't realize this, and many of us don't realize this. The FDA is not authorized to approve dietary supplements for safety and effectiveness before they are marketed. So if we even look at this, in fact, in many cases, firms can lawfully introduce dietary supplements to the market without even notifying the FDA. So some company can be like, I want to put out this blend that's going to help all my patients reduce their anxiety. And they don't even have to tell the FDA that they are putting out this dietary supplement. And we've seen it's growing. So more and more and more and more of these supplements are out there. You can't walk through a CVS, a Walgreens, a Target, H-E-B, whatever, without having this section. So our patients don't always know what they're getting. And in part, this is important because we do see a lot of interactions between some of these supplements and meds. St. John's wort is one of the biggest. We see mental health. It is supposed to help with depression. However, long-term effects, nerve damage, kidney damage, and liver damage. We also see risk of bleeding with maybe increased in patients taking ginkgo biloba or warfarin. So this interacts very often with other substances, with conventional medications. And that goes for a lot of our. We have these other ones. This again is a table I copied just directly from your textbook. Kava. I've always wondered if kava is one I should take because it works well with chronic fatigue. I feel like many of us in nursing, when we talk about nursing school and stuff, it works for us. So kava is one we see. It can help with insomnia. It can help with chronic fatigue. The FDA warns against it though because it can cause liver damage. Our patients may not always know that. Maybe they already have something wrong with their liver and they think a natural substance is a better. I have chronic fatigue. Kava is going to be the solution for me. because I can't take medications that would be prescribed, prescription medications, because I have a history of liver damage. We don't always connect it together. Golden root, again, also anxiety, fatigue, depression. Valerian root, a lot of insomnia and anxiety, more mild side effects than some we see with it. Chamomile is a super popular one. We got those sleepy times tea, where if I take it, it helps make me tired. Lavender is another one we see everywhere. But look, breast growth in young boys has been reported with lavender use. So it is not always safe. Individuals, when we talk about essential oils where we shouldn't take it by mouth, if we take lavender oil by mouth, it can be poisonous. Though we generally think lavender as safe, anxiety, restlessness, insomnia, it is generally thought to be a calming one. Melatonin is another one we spoke a lot in class. I will not talk about it as much today. We got that sleepy time or sleepy girl mocktail that is super popular where we're using tart cherry juice because tart cherry juice stimulates our body's natural melatonin production. But if we do have long-term use of melatonin, our body stops to produce its own. So we do have to be cautious. That helps regulate a lot of times that circadian rhythm, that 24-hour sleep cycle. Fish oil, omega-3 fatty acids, we've talked about that a little bit already, helps out with depression, bipolar. However, if we have a shellfish allergist, we should not take it. It can increase bleeding time. So some of our mind-body approaches, we're going to talk through these. These, again, are ones you're generally familiar with. Meditation. It is super simple. It is most simply accomplished by concentrating on slow, deep breathing and focusing on calming thoughts or breath. Yoga is one we generally know what it is. It in part can help by decreasing cortisol levels in the brain and also by stabilizing the HPA axis, which then lowers our stress response. Exercise alters the level of dopamine, serotonin, norepinephrine. It increases cerebral blood flow, reduces oxidative stress. It can turn on signaling pathways that are responsible for cognitive function and behavior. We talk about exercise a lot throughout the quarter, and it's not like go join a gym and take up CrossFit. It's like go take a 20-minute walk. It does not have to be anything big. I always relate, I know I said in class and some of y'all gave me strange looks, exercise to Legally Blonde. I know it's a little bit older of a movie now, right? Elle Woods' client could not have killed her husband because she exercises, and exercise makes you happy. Acupuncture. We're going to insert a skilled therapist, a provider who's trained in it, is going to insert needles to modulate the flow of energy along body meridians. So this very much is there's key points, those meridians, and by inserting them at those meridians, we modulate the flow of chi. Chi is a life force that circulates throughout the universe and in our bodies, and it should go through precise channels, which is why we need someone who's specifically trained in acupuncture. Guided imagery is one of the simplest. We as nurses can just do this honestly at any point in time. It's been discussed for decades in nursing literature, and it works for anxiety, pain, psychological trauma, PTSD. It works, and there's research with labor and delivery, right? Close your eyes, relax, pretend you're on the beach, right? Feel the sand in your toes, feel the sun on your skin, and we're helping take that patient to a place where they feel happier. Manipulative practices are simply spinal manipulation. This is chiropractics. And Daniel Palmer, a grocery store owner, developed this in the late 1800s. He wanted to heal people without drugs. And he was looking at a way to bring health to muscles, nerves, and organs that have gotten out of alignment. Chiropractic helps with pain, headaches, allergies, asthma, migraine, tension. We can see it with depression, anxiety, and chronic pain. Chronic pain goes hand in hand with a lot of our mental health conditions. We often see this in times in conjunctions with other people, but the main goal of that chiropractic is we want to restore the structure and function of the spine. And by doing that, we are restoring health. Massage therapy, it's soothing and relaxing. If we're talking about it for mental health, we're coming in, right? The lights are dimmed, there's a calming music. There's generally essential oils in play to help create that peaceful smell, and it helps relax us. I broke this up into a few different slides, so it's not so jumbled. Homeopathy versus naturopathy. Homeopathy is pretty much Western alternative medicine. You go to HEB when you have your allergies, you buy that cedar fever type drops, you put those cedar fever drops on your tongue, and it decreases your allergies. And we're giving small doses of the things that you're allergic to help stimulate your body's natural defenses. Naturopathy is health restoration, not disease treatment. So when we are looking again at Western medicine, it's very much, I'm sick, I have allergies, I want to feel better. Naturopathy is more so, how do I combine these things to just make me healthy, not to treat a disease? Aromatherapy is essential oils. Physical, mental well-being, we see these pulled from herbs and plants. They can be applied topically, they can be diffused in the atmosphere, they can be inhaled. Different oils have different effects. However, we have a lot of safety guidelines, and as nurses, those safety guidelines are the most important. We looked at this little link here at the bottom for our kids' daycare in Middleton, Indiana, where they were diffusing peppermint, I think it was, in a daycare, and all of the kids woke up from their nap with like these blown pupils. They had these huge dilated eyes. They were like not coordinated, and they were like, oh my gosh, there is a gas leak. And it turned out the essential oils were just accumulating at too high of a rate in that room. So essential oils should never be taken by mouth. They should not be used near the eye. It is very difficult to properly use these, especially during pregnancy. I know PJ will kind of argue a little bit different, that there are some safe uses, but one of the concerns is we don't want to use these in children under 2. There's a lot of different complications, so we have to be very cautious. We should never put undiluted oils anywhere, really, unless we're sticking it in a diffuser where the diffuser is then going to dilute it. Undiluted oils should never be ingested or placed on your skin. We should always do a test on an area of skin before we apply them through a large area of skin in case there is a reaction. We should keep them away from open flames and keep them in a cool, dark area. But again, simply we have these safety precautions. We are using smell to produce that happy, positive feeling. We don't go into too much detail about expressive therapies, music, and art, right? We talked in class about that neural nostalgia. I am listening to the music of my childhood. It makes me feel better. That very much is what it is. We may not be able to express ourselves verbally, but we can better express ourselves through music and art. One of the last different types of specific therapies we're going to talk about are our energy therapies. And we do have a few: therapeutic touch, healing touch, and Reiki. Therapeutic touch practitioners believe want to balance the client's energy fields through hand movements. They are not actually touching the patient. I'm going to assess your energy. I'm going to do these hand movements and direct your energy to balance it. Healing touch combines a few different types of energy practices, and it does involve laying hands on the body or moving over the body to help regulate that energy field. Reiki is the one that is specifically a Japanese spiritual practice. These practitioners are going to use their energy that is connected to this universal source for healing, and they believe that healing can be done from within. So they can take their energy to the universal source for healing, balance out your energy, and that causes you to start healing from within. So again, historical use of CAM, we'll talk about a little briefly traditional Chinese medicine, and it involves a combination: acupuncture, acupressure, transcendental meditation, Tai Chi. It is very much Eastern tradition, and they are trying to promote harmony and to bring out order or bring out chaos. Ayurvedic medicine is from India. It originated about 5000 BC. So we can see that was quite a while ago. The individual is specifically responsible for their own health, and we have earth, water, fire, air, and space. The body has some vital energies. We are trying to balance all of those vital energies. If it's imbalanced, we treat with nutrition, herbs, exercise, yoga, breathing, meditation, pretty much all the stuff we've talked about today. And that is the end. Doing pretty good. We're right about 29 minutes. And we are going to continue on with Unit 2, our suicide and non-suicidal self-injury. So we talked about this week. We have a few different terms. Suicidal ideation, we're thinking about it, but there's no plan, no means. Everyone would be better off if I was dead. My family would be happier if I wasn't here. But there's not the specific, this is how I'm going to do it. I'm going to go and hang myself. I'm going to go and cut myself. It's just the thought. Suicide attempt is when we engage in any type of potentially self-injurious behavior and we have that intent of death. Suicide is the intentional act of killing oneself by any means. And then we'll see at the end, non-suicidal self-injury, where we are causing damage to our body. We generally tend to think of this as like cutting, burning. One thing to remember about that suicide attempt is it could result in death, it could result in injuries, or there could be no injuries. Someone could have a suicide attempt and their attempt was to overdose and they overdose on maybe 5,000 of acetaminophen and they pretty much walk away okay. What is important to remember that they might walk away with no injuries. If to that patient it was still a suicide attempt, we do have to take it seriously. My 5-year-old patient could be telling me he's going to kill himself by banging his head on the wall, and I know that's really not going to result in death. It might not even result in some pretty bad injuries. However, I'm going to take it seriously even if there is no injury. So epidemiology, we're not necessarily going to memorize epidemiology, but just so we can see it, second leading cause of death for those 10 to 34. Fourth leading cause of death in middle age. We are seeing their incidence of suicide increase. You have a box in your book that talks about statistics, suicide facts 25.1. One I know is interesting, white males accounted for almost 70% of all suicide deaths. So when we talk about those risk factors for it, that's where we start to see men are more likely to complete suicide. Females are more likely to attempt because men are more likely to use those more lethal means. So we do have some comorbidities. 46% of those who are going to die by suicide have a diagnosed mental illness. However, it does list depression, substance use, and psychosis, but we can see anxiety, personality, eating disorder, trauma. Every mental health condition comes with a risk for suicide. We have to treat the coexisting psychiatric disorder to be able to help these patients. What are risk factors? So we have talked already before, risk factors lead to a more negative outcome. The more risk factors, the more chance of an outcome. So if we all will have, right, when we talk about profession, we often forget about our white collar professions to include nurses. So for those of us who are nurses, that is a risk factor. However, if you only have 1 or 2 risk factors and you have a lot of protective factors, things are looking up and are in your favor. The more risk factors, the more likely the negative outcome. So having a psychiatric disorder, having a history of substance use, being male, the older you are, especially when we talk about race, our 75, 80-year-old white male is our most at-risk patient. Religion and marriage can go both ways. If you have a religion that is very much, if you kill yourself, you'll go to hell, you may not consider suicide. Or maybe your religion has a very strong community feel and you have people you can talk to. However, where religion becomes a risk factor is when you have something going on and it doesn't quite connect with your religion. If we have a sexual or gender minority youth, right, a member of the LGBT community who is in a religion who is like, being trans is bad, then this person may be more prone to act with suicide because it goes against it. Marriage can be a protective or a risk factor. You are in a happy marriage, y'all get along okay, we don't have any difficulties. If you are fighting with your spouse, that can lead to increasing risk of suicide. Profession, we always jump to military, and yes, that is a profession that does have high rates of suicide, but white collars, dentists, I don't know what it is about dentists, but dentists have high rates of suicide. We're seeing increased rates of suicide around nurses. Physical health is when we'll talk about repeatedly throughout the quarter. Terminal illness, chronic pain are all things that does come in and play a role. We do have a familial tendency if you have a family history. It does create a link and increase your risks. And usually when we talk about familial tendency this quarter, we want to look at that first degree relative. So not like my second cousin twice removed on my uncle's side. Low serotonin levels. Low serotonin, we know that affects mood. Cognitive. Freud believes that suicide is aggression turned inward. our unconscious is angry at ourselves. Aaron Beck's is what I like the most. The central emotional factor is hopelessness. And we do see a lot of hopelessness in individuals who commit or attempt suicide. I don't have another option is oftentimes one of the things you tend to see. We do have environmental factors that could be risk factors for suicide, fighting with your family, if parents are not monitoring kids. And in kids, we tend to see this cluster of suicide, contagion, or copycat. If someone at a high school attempts or commits suicide, we tend to see more teens and adolescents attempt and commit suicide. A lot of it, again, that immature prefrontal cortex, it's the portion of the brain that controls executive function, where we see judgment, frustration, tolerance, and impulse control. Kids struggle with impulse control. Impulse is a big risk factor for suicide. When 13 Reasons Why came out, a lot of mental health professionals were very upset because of kind of how it glorified suicide almost. Again, a lot more cultural factors. We've talked about a lot of these. Individuals who do identify as a sexual gender minority, struggle with gender identity, are often at higher risk. Bullying, we can talk about bullying all day long, especially in our younger kids. Attitude towards death. If you're afraid of dying, you're less likely to die by suicide. If there's an ambivalence towards death, you're more likely. If we look at those climbing rates of suicide, it increased for all races and ethnicities, except for our non-Hispanic, Asian, and Pacific Islander groups. That is one of the groups where it is not increasing. So again, social factors, relationship problems. If you are fighting with your spouse, your boyfriend, your girlfriend, whoever, if there's a crisis, if you were just raped, if you lost your house, and it was like that one last thing, and that was it. You can't do it anymore. Substance abuse is a huge risk factor, in part because of that impulsivity. Health problems. You were just diagnosed with terminal cancer. You have chronic pain and nothing is getting better. You have been living in pain. Suicide may feel like your only resort out. Financial problems. How am I going to pay rent? How am I going to pay my student loans? It just builds up on you. Legal problems. I'd rather be dead than go to jail. Loss of housing. I have nowhere to live. A lot of housing, financial, health looks at that bottom of Maslow's. LGBT youth and bullying. We can pull up statistics all day long, and we do see extremely higher rates of suicide, suicidal ideation, depression, anxiety in this population, especially depending on where you live. Unfortunately, y'all, we're in Texas. A lot of harassment, physical harassment. They are watching their lives fight out in front of them in politicians' offices. They are getting called names and getting bullied, even if it's not directly in the news. There's a whole bunch of different things that we see. This is very much a population we do need to keep our eyes on. It's been a few years since I've worked with adolescents. 2014 to 2019, I worked long-term care for pediatric adolescents, and of the 7 units at our facility, only 1 unit would accept trans kids. They would not accept them because they're like, we're not housing you. And it was very much a backwards atmosphere at the time, but I managed the only unit who agreed and would willingly take these patients and work a lot with the LGBT youth and bullying. And it was very hard. Kids who grew up in very strict religious cultures trying to talk to their parents about it. And their parents would not want to, or they would not want to use their name or gender affirming pronouns. So it does get extremely complicated when dealing socially with these kids. But when we're talking about treatment, calling them by their pronouns, by their chosen nickname or name, whatever. There's a ton of research that just shows they want to be accepted. And as just simple, super simple, doing that decreases their risk drastically. When we look at our clinical pictures, if you have a history of suicide attempt, it increases your risk of later having a completed suicide. Not every suicide attempt is going to get the treatment that they need. Suicide behavior disorder is specifically in the DSM. I've never really seen this diagnosis used. Usually the patient gets a different diagnosis, but this basically means within the last 2 years you attempted suicide, and it's a diagnosis, a medical diagnosis. So we're going to assess our patient. We're going to look for verbal and nonverbal cues. That overt statement, I'm going to kill myself. A covert statement, everyone else would be better off without me. When we see those covert statements, we really need to investigate why. Well, what did you mean when you said that? We want to look at, when we talk about those nonverbal clues, are they giving away their belongings? Are they writing a note? Are they getting their affairs in order? Were they sudden change in mood? We see more down towards the bottom, that sudden switch from happy to sad. Our patient has come in, they've been very depressed, they're not eating, and all of a sudden they present and they're happy. It's not that we made them better, it's that they have finally come to peace and have decided on how they're going to kill themselves. The lethality of the suicide plan greatly comes into play. If our patient's going to jump in front of a train and there are no train tracks around us, we're not as concerned, but jumping in front of a train is very lethal. If we have a patient and they're like, I'm going to bang my head on the wall versus I have a gun and I'm going to shoot myself. 55% of suicides in America are completed by a firearm. History of attempts and family attempts are a big one. Do you have social supports? If someone has someone to talk to, if they have a safety plan in place that does include individuals who they can contact, it is a protective factor. Health professionals, as we're dealing with these patients, it may be very hard. This person has everything going for them, right? On the outside, when Robin Williams committed suicide, there was very much the public perception of why. He always seemed so happy, right? He was the comedian. He was the funny guy. And there's other things that are often going on. We need to make sure we're talking about our feelings as we're working towards people, as we're working with these individuals. We do have a bunch of nursing diagnoses, simply risk for suicide, and my goal would be my patient still alive. If there is some other type of comorbid psychiatric condition going on, we want to look at those nursing approaches for that condition. We will have a 6-step approach when we talk about planning. We want to limit set. No is a complete sentence. In all our patients, we want to develop self-esteem, figure out what's going on with this patient. Teach self-control, teach coping skills, and we want to get eventually this patient to a maintenance phase where they're going to therapy, they're talking, and they are not currently or actively suicidal. Psychosocial interventions, what's going on? Do they need, or is there a problem with finances and we can get them with a financial counselor? Do they have a problem with housing and we can help them with housing? Health teaching and health promotion very much are those prevention efforts, that primary and secondary. We want to teach coping skills and teach resiliency to kids. We want to screen when someone comes into the doctor I'm taking my kid to his yearly physical next week, and I know the question's going to be, or actually Monday, tomorrow. They always have that. Do you feel down, depressed, and hopeless? We're going to ask those questions to try to identify it. Case management, navigating the healthcare system is hard. If we have good case management set up, we are helping that patient navigate. Milieu therapy is how we're interacting with others on a unit. We always want to document. We tend to forget about survivors, that postvention for those who are there. Suicide is a highly, highly, highly stigmatized still in America. As much as we say, let's talk about mental health, we don't. So we need to make sure we're connecting with these families. We need to make sure that they have the supports that they need. If we have an individual who dies of cancer, we provide support. People are talking about it. There's memorials. However, does not always happen with suicide. We do need to constantly evaluate these patients to see if there's any changes. Environmental safety guides we've talked a lot about throughout the quarter. Plastic utensils, we're going to use them. I'm going to have it numbered. I'm going to know how many, just because I don't want a spork to go missing. We generally, for a patient who is acutely suicidal, do not want them in a private room, and bedroom doors stay open. All other doors are locked. If the patient is not in the bedroom, though, we're going to close and lock the door. Because we don't want them going in the room and us not being able to find them. Jump-proof, hang-proof bathrooms. We're not going to have like lighting fixtures that they can hang themselves from. All the bathroom fixtures are going to be recessed. The shower head is going to be from the wall. The shower curtain is going to have Velcro. Gifts don't really happen. Families can drop off some belongings, but you're not getting like a vase of flowers. Kids who would get coloring books, we would look to take out the staples. So we very much are searching all of these things. It is not a violation of your rights for us to search them, especially mental health. We want to make sure that the harmful objects are not reaching the patient in any way, shape, or form, or that patient A had something and she left it behind, and then patient B found patient A's belongings. Went through a few questions, but we're going to skip through them now because we did them in lecture. Pharmacotherapy for whatever else is going on. Psychotherapy, clinical supervision, checking on the patient, putting them on a one-to-one, making sure we're sitting there watching them. You don't have a right to privacy when you are at risk for suicide. We can do brain stimulation therapy. Advanced practice roles are a lot of those therapies, that cognitive behavioral therapy and the dialectical behavioral therapy. We're going to skip through some of these questions and go to non-suicidal self-injury. Prevalence, 6 to 23%. We see this more in adolescents and college students. Generally by 30, it's declining, more common in females. We do see this with other mental health disorders, borderline personality, depression. We have a bunch of risk factors. It really is just depends on what's going on with their patient. And you'll see a lot of our risk factors start to overlap. Assessment, we have to be empathetic. It's really hard with these patients because they may be self-conscious, and if the very first time we're like, hey, I'm going to do a skin check, I want to look at your skin, we let it show on our face, that can be very in itself triggering for our patients because they know they're wearing long sleeves or keeping the stuff covered. We do have self-mutilation nursing diagnoses. Outcomes are going to depend on that nursing diagnosis. Again, we will see this planning six-step approach, and really there isn't much difference between this and what we saw for suicide. Figure out what's going on and why, develop that self-esteem. If you are using cutting as a coping skill, what is something else that I can do? Am I going to give you ice to hold? Am I going to give you a rubber band? Implementation, we do have to care for injuries. If our patient comes in and they cut themselves and they are bleeding, maybe they severed a tendon. Those are things that happen to ligament in their wrist. We do have to care for those injuries. We still will always have to develop that therapeutic relationship. That will never go away. But oftentimes, if they're unconscious, if they're bleeding, we stop the bleeding, then we do that. That's the one time. We may do therapeutic relationship first because we have to stop the bleeding. We want to teach coping skills. We want to do a dialogue. I see you pacing. Are you anxious? And hopefully be able to put words and get that conversation going with this patient. We want to evaluate their communication, evaluate their perception. For them, it may not be anything big. Pharmacotherapy is going to depend on what other comorbid conditions going on. We talked in class, not so much a huge one. Naltrexone is one I've specifically seen. And we talk about naltrexone quite later in the quarter as a medication for these conditions. Psychological therapies, what we're seeing in our advanced practice nurse, cognitive behavioral therapy, dialectical therapy, group therapy, all sorts of different. And we're almost done, y'all. I got 13 minutes for death, dying, and grief. I'm going to see if I can do it. This should go pretty fast because I know this is one y'all talk about in other classes. It's not just here. There's been a blurring between life and death because we have all these things that are keeping people alive. We can do transplants. I can stick you on a ventilator and keep you alive forever. In the 1960s, Kubler-Ross came across with her 5 stages. They're not linear. We can enter at any one point in time. There is no specific, you will be in denial for 5 days. Then you'll move to anger for this many days. It's going to vary. Denial, I don't have a problem. I'm going to see someone else. You're wrong. And we go get that second opinion. Anger, we're angry at the healthcare system. God, we're even angry maybe at the person who passed away. If you wouldn't have done this, you would still be alive. Bargaining, I would do anything to be able to live to see my kids graduate. We're attempting to gain control. We are creating that deal with that higher power. Depression, sadness is setting in, that regret, that pain. And we're just depressed. Acceptance does not mean that we are okay with the person dying. We're okay with ourselves dying. Acceptance just means we understand that our life has a new meaning, that there's a new plan in place for our life. and we're looking at what's going on. So palliative care versus hospice. The goal of palliative care is to limit pain and discomfort, The goal of hospice is to limit pain and discomfort and not prolong life. Palliative care very much starts that discussion, but you do not have to be terminal to enter palliative care. Hospice does have a life expectancy of 6 months or less. It's available regardless of age diagnosis. We can have individuals who are pregnant on hospice because we know that that baby will pass away. So it's not limited just to 95-year-olds. It is focusing very much on patient care, not patient cure. And we do have that multidisciplinary. We have multiple people involved. We want to honor the patient, right? We want to enhance that quality of life. We want our patient to die with dignity. We do have to communicate, respect their autonomy, what the patient wants, or if the patient is not able to make those decisions, the family members. The family and the patient direct care, we want to honor that dignity. Therapeutic relationship first and foremost. Baby shower once, and someone was like, "Oh, what do you do?" And I was like, "I'm a nurse." And they went into this huge story about when their mother passed away and the hospice nurses who were there for them. And it kind of just shows that that is what, like in that moment at that baby shower, what that person wanted to tell me when I was talking to them about how amazing and wonderful those nurses were in helping the family. That is first and foremost our job at the end of life, talking and communicating with those patients. When it comes to helping with end of life issues, right? Advanced care planning, funeral home arrangements, right? Talking about life sustaining measures, and we'll talk about those on a separate slide. Is hospice necessary? Getting into hospice, helping with pain, helping with constipation. And we'll talk about pain medication on a separate slide. Pain medication is so important. We do have a few different types of documents for advanced care planning. Power of attorney for healthcare. Someone else is going to make medical decisions if I can't. Advanced directive, how I want those decisions to be made if I can't make them. And a living will specifically outlines those things that keep me alive. If I'm brain dead, I do not want to be on life support. Just let me die and give someone else my organs. That very much is the specifics in the living will. If I have to have TPN, but I don't need to be on a ventilator, sure, keep me alive. Power of attorney, someone specific. Advanced directive is kind of how you want those decisions to be made if you can't. A living will outlines the specifics. When it comes to advanced care planning, we do have to talk about withholding, withdrawing of life-sustaining treatment. So this is, do we want to be a DNR? Do I want mechanical ventilation and artificially nutrition if that's the only thing keeping me alive? When it comes to dying with dignity, it's a human fundamental right. Our patients should have the autonomy and the independence to make decisions. We don't want them to be in pain. We want to relieve symptoms, whether it be constipation or dry mouth, as small as that may be, to keep them comfortable. We want them to be respected. We want them to be treated as a person, not just a patient or a body. They should get adequate care by competent caregivers. So when we talk about nursing care at end of life, this is very much that pain medicine. We want that palliative symptom management. There is such thing as a rule of double effect, and that means that our medical providers can prescribe pain medication, even though the medication might cause the patient to die sooner. Now, there is little evidence that pain management adequate is going to cause the patient to die earlier. However, it is very much a concern when we look at family members. And honestly, even sometimes when we look at nurses. I had a patient who was passing away. They were on hospice. They were in a lot of pain one day. I gave them the prescribed dose of pain medication, and within 2 hours, they were dead. That medication didn't necessarily cause them to die, but it allowed them to die and not be in pain. And that is very much how we have to look at it. Artificial hydration and supplementation. Eating and drinking is such a common part of life that it's hard when our loved one may not be eating or drinking. We don't often understand it. We talked a little bit in class about my grandmother-in-law, my husband's grandmother, who's 93, late stages Alzheimer's and dementia. And the family had such a hard time when she stopped really wanting to eat or drink. And even though the doctor said 200-300 calories a day is all she needed, they were forcing her. If I hold her nose, she opens her mouth, I can put a spoonful of food in. However, when we look at Alzheimer's, patients tend to die from pneumonia, specifically a lot of aspiration pneumonia. Lack of food and water is not the cause of death. It is a symptom of approaching death. If we do provide artificial hydration supplementation, there is no benefit shown. And we're more likely to have a lot of negative side effects: edema, congestion, ascites, nausea, vomiting. So we do have to make sure the family is aware of that, and provide that support and talk to them appropriately. Physician-assisted suicide, I like the phrase medical aid in dying better. We have a lot of arguments for and against. The American Medical Association, a lot of disability rights groups, the American Nurses Association have published statements related to physician-assisted suicide, and a lot do oppose it. We do have some groups that do like it. Individual liberty. And autonomy, our patients have a right to make decisions. But on the flip side, the government has power to override certain rights and protect citizens from irrevocable acts. That argument that the government has a right to protect citizens is how and why physician-assisted suicide is not legal in America, but it is legal in certain states. So it does get kind of backwards. Autonomy, our patients have a right to make their own decisions. Non-maleficence, is helping in a patient's life harmful? Most providers take an oath to do no harm. And if we are providing medication to patients at the end of life, we may be doing harm. Beneficence, doing good means to provide and support life. Oregon, Washington, Montana, Vermont, California, and Colorado, it looks like, are the states that allow physician-assisted suicide or medical aid in dying. Your book, will always caveat say it takes this very anti-physician-assisted suicide approach. I always like to say this is a personal decision. And honestly, is there even a right or wrong? It goes a lot into nursing ethics and medical ethics and bioethics. Their presence, being there for the patients, asking those open-ended questions, not just leaving them in a room by themselves, but sitting there and talking to them, using that therapeutic communication. We will never, ever, ever use cliches. At least they're not in pain anymore. At least you are happy, you were married for so long. Just stay away from it. Anticipatory grief, we're mourning in advance. We're understanding that our future is going to be different. We may be angry. We see this frequently with Alzheimer's, with dementia, where once that diagnosis comes into play, we start grieving. We see this once those curative measures are stopped and an individual moves to hospice, because we know that it's only a matter of time. And we start grieving at that end. We do have some developmental tasks, right? We want to connect with our loved ones again. Maybe we want to say goodbye. Maybe we want to make amends. We accept the finality very much. Erik Erikson, we are looking back, and does our life have meaning? Are we happy with what has happened? If we're 98 years old and sitting in a rocking chair on our front porch, and thinking about our life, what are we thinking about? We're getting our wills in order. We're planning our funerals, maybe. Physical signs that we may see death approaching in our patients: they grow tired, they're losing their appetite, they are increasingly tired. We do see changes in mentation. They're just not able to process information and stay awake for as long. Circulatory changes: the heart rate increases, but the blood pressure decreases. There's a lack of blood flow, especially to the extremities, so we start to see that mottling, gray blue splotches on our extremities. Our body stops producing urine, and we have breathing changes. Those Cheyne-Stokes respirations are specific, one that we do tend to see at end of life. We also tend to see an increase in congestion, so there's almost a rattling to the breathing. We can't clear secretions. So when we're talking about palliative care and dementia, we want to anticipate needs. These patients can't always say what's going on when they do lose communication. So we want to anticipate. We want to keep them pain proactively. We want to manage depression, manage side effects. We may have to stop medications. You know what? You've been on this medication for like decades, but is it now causing more harm? A lot of medications, especially our anticholinergic medications, affect our elderly patients more. After death, we have a few different words, periods. Bereavement is the time period. So bereavement is a time that follows death. Grief is the response, our emotions almost, what we're feeling after a loved one has died. Mourning are the things we're doing to help us cope. Are we having a funeral? Are we sitting Shiva? Are we having a wake, a celebration of life? We have a few different theories. We talked about Kubler-Ross already. The goal of mourning used to be like getting over it and moving on, and now we understand it's a more complex process. Our life has transformed, our identity has transformed. My maternal grandfather passed away and my paternal grandmother passed away. And then I was somewhere and my both remaining grandparents, one from each side, were together. And it was honestly the most depressing conversation ever. Because it was a lot of that, how is my life different? They had all been married, one set for 50 years, the other set from was 60 years. And it was very much how their life has transformed, how things are different. You know, how are we moving on? How do we go through these relationships when that person we had been with for so long is not there? Social media is very much newer. Facebook, you can memorialize your Facebook. You can say, hey, when I pass away, I want this person to have control of it. So we are seeing that as a separate approach that used to not exist. Grief versus major depression, I will 100% admit we have not talked about depression yet. We do see a lot of the same symptoms. One of the big differences is when we're talking about depression, it more has to do with that individual who passed away. When we're talking about grief, and that specific time period. So if we're talking about grief, I'm guilty that I didn't spend enough time with the loved one. If I'm talking about major depression, I just feel guilty all of the time. If we're talking about the physical symptoms, right, I have decreased energy with grief that will gradually improve, but with major depressive disorder, it stays the same. Got 2 more slides. We're almost done. It took me a little bit more than an hour, but we're getting there. Complicated grief, it's not following the normal expectations. Functional impairment. I'm having this preoccupation with thoughts of the deceased. I'm feeling empty. I'm angry. I have depression and disbelief. I'm detached. I'm self-blame. I may obsess about, it's my fault my loved one didn't pass away. I didn't encourage them to go to the hospital soon enough. We might not be eating or drinking or going to church or out with friends like we used to. Our ADLs might not be happening. Disenfranchised grief, it's not socially recognized. So as a caregiver, we are going to feel grief and mourn our patients when they passed away, or at least we should. But we have to look at how it's happening. If we lose a pet, I will always say, I will argue about this one a little bit, because if my dog passes away, I'm going to mourn my dog. However, it is not always looked upon the same and is not socially recognized between different organizations. Abortion is a big one that we're seeing, especially nowadays in this society post Roe versus Wade. Individuals you leave the state of Texas to get an abortion and you come back and you can't talk about it. So self-care for nurses, we will talk all quarter about this. This is not happening to you. I have a love-hate relationship with that statement. We are losing a patient. In that moment, though, we have a duty to take care of the patient and their family. However, after the fact, we do need to talk to someone. We need to create that balance. Private life, we need to do our own set of mourning practices, and it could be different for all of us depending on the environment. If we find out through the grapevine that a patient we just had left and then passed away, versus maybe we're doing CPR that is unsuccessful and a patient passes away that way. Protect our private life. Don't pick up extra shifts. Say no to your boss. Make sure you're eating, drinking, and sleeping. And that is it, y'all. We are done with Unit 2. If y'all have questions, please let me know. Otherwise, happy studying.